first speaker is Dr. Satya Prakash Tiwari. So Prakash, please go on to your presentation. The legacy of ILM peeling beyond macular holes.
Good afternoon, all of you, and respected chairpersons. This is actually a industry-sponsored talk by Novartis, overcoming the current challenges in diabetic eye disease. There is need financial disclosure. So, what are the current challenges in managing the diabetic eye disease? Challenges may be related to diagnosis of the disease, treatment of the disease, or once we initiate the treatment, adherence to the treatment protocol by the patient is also a bigger challenge in management of diabetic eye disease. We will come upon these factors one by one. So, as far as the diagnosis of diabetes is concerned, early screening the patient at right time is the biggest challenge. Still in India, majority of our physician colleagues or endocrinologists and diabetologists, they generally fail to stress the point to the patient to go for an eye screening regularly to detect any diabetic eye disease on time, and that leads to complicated disease at the presentation, which generally leads to poor outcome. If we screen a patient on time, then definitely we can save all these complications in cases of diabetic eye disease. As we all know that throughout the world, population of diabetes is being increasing day by day. Currently, 463 million people are suffering from diabetes, which is expected to increase to 700 million by 2045. So that is a huge population burden needs to be catered for diabetic eye disease. And out of those diabetics, any form of DR is seen in 27%, DME is seen in 4.6% of anemia, and 1.4% people develop neovascular form of diabetic retinopathy. So 1 out of 5 patients get diagnosed with diabetes, and DR can go undetected in the rest of them, leading to poor visual outcome and delayed diagnosis. Now, after diagnosis, coming to the treatment. So, as far as treatment part is concerned, treatment of DME is very important because DME is the most common cause of defective vision in cases of diabetes. And we are treating all our patients mostly with anti-VEGF. Laser has taken a backseat in management of DME. We are generally not treating with laser as a primary treatment. Injections are being given. But infrequent injections, poor outcome, lack of regular follow-up, and lack of loading dose concepts leads to generally poor outcome. Now, multiple studies have shown that if the patient is offered a loading dose treatment for diabetic macular edema, the response, short-term and long-term outcome is much better as compared to lesser and infrequent injections in diabetic eye disease. In this slide, we can see that visual acuity gain is directly proportional to the number of injections given, and that in the first year of treatment, it is very important. If we do not give loading dose, the results are relatively poor as compared to loading dose treatment. Another factor is adherence to the treatment. That is very, very important. As we all know that all diabetic patients develop multifactorial disorders like lower limb amputation, neuropathy, then nephropathy, cardiovascular disease, stroke. So at the same time, they need many types of medical treatment and multiple appointment through different specialties, and that leads to lack of adherence to the patient. This survey shows lack of follow-up by the patient due to cancellation of appointment, no show, and many times in India also we see a lot of patients, they do not turn up for their scheduled appointment for a follow-up treatment, and that leads to poor outcome. This comorbidity and loss of productive time are the contributor factors in patient non-compliance. So what we see here that DME patients who are non-adherent to treatment in the first year of anti-VEGF therapy, they generally experience 10 times higher rate of clinically significant vision loss as compared to patients who are adherent to treatment and they follow up regularly. So that is very important point. On this slide, you can see that all the studies were done as a randomized controlled trial where the patients were enrolled and follow was strictly monitored within a time frame, the outcome was much better. While the real world study or phase 4 trials or data shows that the outcome was inferior. Why? There was only one factor important in that. In a study, we always get a follow-up at a regular time. If a patient is not following it, that is deleted from the study. But in real world data, we include all patients. So that emphasizes the importance of regular follow-up and timely treatment. Non-adherent patients with DME treatment pose a higher risk of visual acuity loss. 1 in 6 patients and 1 in 10 patients were lost to follow-up within an interval of 6 months and 1 year respectively. It was shown in many studies. Yes, so what we see here that early initiation, that is diagnosis of DME at an earlier stage and starting treatment with anti-VEGF molecule was the most important factor to get better visual outcome in patients of DME. Rise and Wright demonstrated that a delay of 24 months in initiating DME treatment lead to significant visual, insufficient visual acuity outcome. And visual acuity outcome was much better in patients who received loading dose of ranibizumab. Better improvement were observed in patients who received more than 4 ranibizumab injection in 12 months. And non-adherence is associated with inferior clinical outcome in patients treated to DME. So DME has highest proportion of patients not adhering to treatment. So we can emphasize to all these patients about the early diagnosis, adherence of treatment, and initiation of loading dose treatment, a strict follow-up in at least first year of treatment, and lot of patient support program is also going on by the industry also, especially that Novartis people are offering one free dose from after every 2 PET vials. So that actually helps a patient in getting proper treatment, at least receiving first 3 loading doses, and that will help in good outcome for DME patients. So thank you so much for your attention.
Thank you very much. So Prakash, tell me 3 major challenges from the point of view of the patients in the management of diabetic macular edema or diabetic retinopathy. 3 major challenges from the point of view of patient.
Sir, from the point of view of patient in our scenario, finance becomes one of the major challenges. The second most important challenge is that lack of accompanying person. Majority of our diabetic population is relatively older, is retired people, and majority of them, even if they are financially stable, their kids or attendants are living in some other city or they are busy in their work, so they cannot accompany. Although they are having money, they can come to clinic, but there is nobody to take them to our clinic. One of the most important factor I have seen is that lack of awareness, especially on the part of physicians. They do not tell them regularly that since you are a diabetic, even if with good control, you may develop eye-related complications. So you should see your eye specialist also regularly for the screening of your diabetic eye disease.
Thank you very much, and good presentation. And most importantly, for all of us, that the diabetic patients know they get inpatient. How many injections? There is no cure. When a patient comes to me, sir, I have already had 10 injections. So when he says 10 injections, then you have no answer. Then I say that is diabetes curable? He says no. I said if diabetes is not curable, obviously the diabetic retinopathy, as long the diabetes is there, the diabetic retinopathy will be there, and our job is only to manage as and when things arise and things come to us.
And sir, likewise, even I counsel my patient कि जब आपको इंसुलिन लेना पड़ता है डायबिटीज में, you are taking every day twice or thrice, so that is also an injection. For eye disease, at least you need to take injection every month, and it is also a finite disease. If you be followed regularly, your eye disease will be cured at some
Thank you,
point.
Sir Prakash. Thank you very much.
Sir, I have a question, sir. So do you do 2 injections of the same patient in the same day? Both eyes, do you do in the same day, same sitting?
Both eyes?
Diabetic macular edema.
Same time, both eye injection. No, we do not generally.
Please don't do that. But there are some, very, heroes are there who do this job, but I will ask not to do this. Anyway, the next presentation is, I'm sorry, I told the topic first, the legacy of ILM peeling beyond macular holes. Rahul.
Thank you, sir. Good afternoon, respected dignitaries on the dais and off the dais. The ILM peeling, the first report of vitrectomy for treatment of macular hole was published way back in 1991 by Kelly and Vidal, after which 1997 McAmmer published the first report of ILM peeling in cases of macular hole, and ever since then it's been widely accepted as a treatment by all the retina surgeons, mainly because it increases the closure of the macular hole and reduces the chances of reopening of macular hole. It is a acellular basement membrane of Mueller's cells on the inner retinal surface. It has maximum thickness at approximately 1000 micrometers, and it is thinnest on the tip of the fovea, and then again becomes thinner in the periphery. Even though it is thin, it has a mechanical strength of megapixels, which is like an articular cartilage. And interestingly, it has 5 times more thickness on the inner retinal surface than on the vitreous side. So probably that is the reason for the centrifugal pulling of mechanism for the creation of idiopathic macular holes. It is about 1000 times stronger than a cell layer, and it imparts about 50% of retinal rigidity, and it forms a scaffold for proliferation of various cells, which leading to the tangential contractile force. So once we remove the ILM, it leads to reduction in the retinal compliance. So basically can I is there a speaker?
Overhead lights.
How to raise the voice? I'm unable to assess it from here. Volume बढ़ाना है थोड़ा. नहीं, यहाँ से कैसे असेस करूँगा मैं? आवाज कम करो. Please reduce the volume, please. So the critical step in ILM peeling is the initiation of peeling, which can be done with the diamond dusted scraper or finish loop, or most of the surgeons prefer a pinch technique. Once the flap is created, it can be circumferentially expanded like a capsular axis with the help of specialized forceps like ILM peeling forceps. Various methods are available, which says inverse peeling, which increases the anatomical closure rate. There is presently no concerns about how far the ILM should be peeled, but a larger peeling is better, because it has been shown that it increases the anatomical closure rates. There are cases when there is external limit ERM present along with the chronic macular hole. So one can start with the reverse staining, and an ILM flap can be created. Once the ILM flap is created, ILM along with the ERM en bloc can be removed, similar to a simple ILM peeling in some cases at least. Once the ERM is removed, the ILM underlying should also be removed, so that there is no scaffold for reproliferation of ERM, and then the ILM peeling can be expanded around the macula so as to reduce the ERM. This type of patchy staining of ERM is typical, and sometimes these ERMs are very thickly adherent, so it's a good idea to start the peeling the stained ILM and slowly progress towards the macula. It's easy to find the edge of the ERM this way, and once the ERM edge is found, that can be very well removed. But a restaining of the underlying ILM is essential, so as to make sure that the complete ILM is removed once the ERM is removed. At times the whole of the posterior pole is having an adherent ERM, and also the cortical vitreous attached to it. It happens maybe because of incomplete posterior vitreous detachment or vitreous schisis, and whole of these membranes can be very well peeled off. Again, restaining and assuring that there is no remnants of the ILM remain around the macula is important. In cases of the tractional retinal detachments, these membranes are very much adherent, and finding a right plane of separation is important, because otherwise it might lead to iatrogenic hole formations or bleedings. So again, the ILM peeling can be started, and once you get a edge of adherent vitreous and ERM complex, it can be gently peeled. So ILM peeling in these patients has again many benefits. It has been shown to have a less tangential force. So the ILM, once the ILM is peeled, the macular edema is also less, and once these membranes are removed, along with the ILM, the reproliferation of ERM, which happens in quite a significant number of patients, can be reduced. Once you get the right plane, with this just with the forceps itself, we can remove whole of this thing. At times, with the tag is very much adherent, that can be trimmed with the help of advanced cutters, and we can have a attached macula. In cases where there is a retinal detachment with macular pucker, it is imperative that one should remove the epiretinal membrane before you settle the retina, because a lot of post-operative visual acuity depends on this thing, and once the silicone oil is there, this ERM proliferates even faster. So in these cases, the peeling should be away from the disc rather than circumferential. Once the ERM is removed around the macula, then ILM can be peeled and extended all around. There are reports which shows that once the ILM is peeled from these detached retinas, there is less chances of reproliferation. Even when there is no macular puckers and there is detachment due to large holes, it is a good idea to remove the ILM, because these are the patients who can develop post-operative macular ERM, because this is one patient which operated for superior 200 degrees of giant retinal tear with vitrectomy alone and placing a silicone oil. Initially patient was fine, but after 2 months it came with macular pucker and inferior shortening of retina and PVR. Retinal fold can be seen. So once these membranes are formed, they are more difficult to remove. They are more adherent to the underlying retina. They are not like the normal ERMs, and you can see that this is a fibrotic membrane which has caused a macular fold also. And again, the ILM from parafoveal area, because it is the thickest portion of the ILM, around 1000 microns from fovea, can be started. Due care has to be taken in these cases not to cause iatrogenic macular hole. Once this fibrotic membrane comes out, we can see that the macular folds are opening up, and then the ILM peeling can be expanded around the macula so as to relieve as much as tangential traction as possible. This patient, the relaxing retinotomy was done, and then the oil was placed. So we could achieve the retinal attachment after the resurgery with good anatomical outcomes, but this could have been avoided if we planned the ILM peeling at the first surgery itself. Thank you.
Thank you very much.
Very good. Sorry. Yes, doctor.
No, I have a Sony camera, 4K camera, on which I am recording. It is attached to the microscope with the. No, it is 4K camera. Unfortunately, we don't have a recording which can capture the videos in 4K. Once we capture, they become HD quality. Right now.
Very good videos.
Thank you, ma'am.
You suggested peeling membranes in any RD which is suspect grade ERMs. Only thing is, I would say a word of caution, because you are operating in retina detachment, and you now don't want to create macular tears, macular holes. So depending on the skill of the surgeon, and not necessarily every case.
Yeah.
If you're not confident, better to leave it. He may not develop ERM.
Right. Yes, ma'am.
But very good videos.
Thank you, ma'am.
The next presentation by Dr. Rajesh Sahai.
Deepak is talking on management of anti-VEGF resistant AMD.
Good afternoon to everyone, respected chairperson. As you know that AMD is a chronic disease and one of the important causes of irreversible visual impairment worldwide. And despite a number of intravitreal injections of anti-VEGF, which is the first line recommendation, there is still persistent fluid and recurrent exudation. And keeping the patient fluid free becomes a problem. And this has been seen in the CAS trial also to show that 51.5% of patients receiving intravitreal ranibizumab and 67% receiving bevacizumab have evidence of persistent fluid on OCT. So there are still around 20-30% of patients with active exudation on angiography or OCT after 1 year of regular therapy with aflibercept. So if you come to the definition, what is refractory AMD? Any persistence of exudation evident on clinical or imaging studies, or even increasing hemorrhage, despite 3 to 6 months actually of monthly anti-VEGF therapy can be labeled as a refractory AMD. And it is important to know this because then it gives us time to actually switch therapy for AMD. Eyes which have shown complete resolution of retinal exudation once the treatment is withdrawn with a multiple recurrence of at least 2 times can be labeled as a recurrent neovascular AMD. Depending on the responder status, a good response can be defined as that when the resolution of fluid, where there is resolution of fluid and improvement of more than 5 letters. A poor response if there is less than 25% reduction from the baseline. So basically the poor response and non-responsive patients are those who become refractory to treatment. So what are the important causes of resistance? And it has been shown that there can be a misdiagnosis, genetic variants, there can be pharmacological tolerance, which can be dynamic or kinetic tachyphylaxis and alteration in the neovascular architecture, and other redundant angiogenic factors which play a role in the pathogenesis of AMD. So misdiagnosis can happen where an IPCD patient sometimes can be diagnosed as just as a CNDM, RP can be missed, and these patients actually need a strong anti-VEGF, and if treated with bevacizumab may not actually respond. So genetic variants are also there where numerous genetic variants such as CFH and the ones mentioned here are conferred significant risk for development of AMD. Any polymorphism associated with RS1061170 has been strongly associated with exudating AMD and progression. So there is also Lee et al. Found that harboring the homozygous CFH required additional ranibizumab injection. In other words, the response to treatment of AMD differed according to the patient's genetics. So these genetic variants may also have higher levels of inflammation, which leads to actually fibrosis and less therapeutic effect. So it is conceivable that future AMD treatments may depend on patient's individual genetic risk profile, and intravitreal exogenous CFH or CFH-related complement inhibitors may actually be beneficial for these patients. Pharmacodynamic tolerance may be caused by the increased expression of VEGF. There may be an increased expression of VEGF receptors, changes in signal transduction, or a shift in the stimulus of CNVM growth. Pharmacokinetic tolerance can develop with a decreased quantity of the substance reaching the site, systemic immune response, neutralizing antibodies, increased clearance from the eye, or a reflux of the drug. So the biologic lens application actually showed that there is immunoreactivity to ranibizumab in 1 to 6% of patients receiving monthly doses of ranibizumab,
and therefore theoretically it may be beneficial to increase the dosage or shorten the treatment interval. But practically this is not possible because the high levels of anti-VEGF did not actually show a very added advantage, and frequent dosing will have compliance issues and is not approved by FDA. Tachyphylaxis, if it develops, stop the treatment, switch to a different group of drug, and this, by switching the drug, actually the different molecular sizes and transport of these molecules to the subretinal space may help. So aflibercept and brolucizumab may help in patients with persistent fluid. There may be an alteration of the neovascular architecture where vascular endothelial cells play a crucial role in vascular formation, and endothelial cell mutation may lead to a conformational change in the receptors. In addition, anti-VEGF therapy may promote apoptosis of these endothelial cells and leading to empty vascular leaks, and this causes persistence of the pericyte and the vascular basement membrane, and this leads to a resistance to the regression of CNVs. So chronic inflammation may also be there, which causes structural damage to the vascular walls and leads to permanent vascular permeability, and inflammatory stimulation could also increase fibrosis. So mutations in endothelial cells, maintenance of vascular leaks, inflammatory changes all lead to a resistant CNVA. A combination of anti-inflammatory agents or anti-fibrotic agents may play a role in resistant CNVA. Various redundant pro-angiogenic factors like fibroblast growth factor, transforming growth factor, tumor necrosis factor, platelet-derived growth factor have been also implicated. So, anti-platelet-derived growth factor may actually help in managing these resistant cases, and Fovista is one such drug which is under trial at present. Anti-VEGF therapy can also enable VEGF-induced neovascularization, but sustained activation of complement system may lead to increased inflammatory response, and therefore a combination of immunomodulators may help. Triamcinolone along with anti-VEGF may help. Tandosporine and serotonin receptor agonist has a local neuroprotective and anti-inflammatory effect, and complement system modulating substances such as antibodies, peptides, aptamers, and antibody fragments like lampalizumab have shown promising prospects in AMD therapy. So to conclude, despite outstanding advances made by anti-VEGF therapy, most patients require repeated injections and long-term treatment. Switching to aflibercept or brolucizumab may be effective in such patients. And besides VEGF pathway, other redundant pathways do play a role in the pathophysiology of AMD. Thank you.
Thank you. Deepak, tell me one thing. Would you like to differentiate between tachyphylaxis and non-responder?
Non-responders are those who do not respond even with the first injection of the drug, and non-responsive if despite 3 to 6 injections they are not, the fluid is not regressing, there is an increase and sometimes there may even be an increase in the hemorrhage or fluid. Those are non-responders. Tachyphylaxis is one where the patient is initially responding to the drug, but suddenly it stops responding to that.
Simple answer is tachyphylaxis is related to the drug. Tachyphylaxis is related to the drug. It's because of the drug, he's not responding. Non-responders will include tachyphylaxis also. Non-responder could be for various reasons, so many reasons, what you have presented just now. And tachyphylaxis is mainly related to the drug.
The other modality of treatment is photodynamic therapy. Have you mentioned? So I have a very vast experience with these photodynamic therapy, where we used to have 15 years, 10 years back, patients not responding to injections simply. So photodynamic therapy, at least in 60-70% of the patients, works right. And especially if it is PCV, then it is pretty specific actually. The polyp closes much better than with anti-VEGFs. PDT is a very good thing which we don't have in our country right now.
We have not used, because it was used for a very long time, and I think it's Until this period, we were only using PDT. I have done 11 PDT in a day in RT center. Yes. So
Just wanted
maybe,
just wanted to add on.
pardon? Yes,
PDT still is one of the best treatment for PCV, but as we do not have it now, I would like to share my experiences with Dr. Suzumab or this new drug from Novartis. It is an excellent drug for PCV and refractive cases for wet AMD, because these cases are very unhappy patients who have had many injections. And in my trials, and also at 2 centers also, I would like to quote, the response to Bluxusumab has been excellent, and the response with PCV is also paginous. Yeah. And also, I would like to add one comment that when the patient does not respond, especially the one-eye patient, I think there is no option left after if we have used Bluxusumab or paginous to put a injection of indeximan plant.
See, before you go to clonazepam, doctor, do you try something safer like aflibercept?
I think Bluxusumab is the safest drug. We have
No,
tried it.
efficacy there is no doubt about it.
I have tried.
Safety is the issue.
Safety, we had no complications in more than 200
No,
patients.
you don't have to have it yourself. There are enough happening around us, so it's just a matter of time when it happens.
Because I have not seen it in many patients. In my,
I hope you don't see it.
I have not.
Next. The next presentation is pediatric erectile sector attachment, spectrum and management, Dr. Abhishek.
On the outset, I would like to thank AIOS for giving me the opportunity to share my thought process on pediatric rheumatogenic retinal detachment. And what more pleasure than to present to my guru himself, who is the doyen of pediatric retinal detachments and pediatric surgery. Thank you, sir, for hello, and thank you, Malika ma'am. So, rheumatogenic retinal detachments in the pediatric populations are relatively uncommon. The etiology can be congenital or acquired, and in acquired trauma, myopia, aphakia, and less common etiologies are there. The detailed history is very important. Like if you want to differentiate, you have to ask for a history of prematurity, infection, prior ocular surgeries, any genetic syndromes that is running in the family, or prior trauma. Nystagmus can be an important clue to the age of insult. So ROP, PHP, FEVR, Nuri's or other diseases, if you have a concomitant nystagmus, it helps you to differentiate the age of insult. Presence of strabismus may indicate a chronic retinal detachment, and RDs can also present as leukocoria in almost 10 to 15% of patients. Ruling out retinoblastoma and doing a careful meticulous ultrasound B scan is must. Bilateral retinal examination is a must for pediatric detachments. Younger children may be unable to cooperate with a depressed retinal examination, so do an EUA. In patients with poor pupillary dilatation or ultrasound B scan should be again performed. Management can be challenging and varies significantly from traditional management in the adult population. My golden rule is that if any of my patients with pediatric RDS, I would do a buccal first. Even in borderline case, which it is heavily weighing on the PPV, I would do give a trial of buccal, and I do surprise myself a lot. Subretinal band is not a contradiction to do a scale buccal in pediatric cases. Encircling band is quite common in my practice if I am doing a PPV, and when the most important thing is to do a meticulous PVD and a meticulous PVD. So the very first of if you are doing a pediatric PPV in a pediatric case is to do a meticulous PVD, and for in my hand, this diamond dusted old my friend is most helping hand. I do stand for look out for the cortical vitreous, and in almost every case we have a thin remnant of cortical vitreous. What I do is I induce a circumpapillary elevate the edge, and then I shift to my forceps to induce it further towards the equator. Once I have significantly induced in a circular manner towards the equator, I put a bubble of PFCl to stabilize the posterior pole, and then I shift to the cutter to further extend to the periphery and as far as possible. And generally, we have a support of encircling band all around, but it should be maximized as much as possible. Now, trauma is an important case in pediatric retinal detachments, and this is a case of a female who was coming with a bullous RD post corneoscleral repair. And in this case also, this was a bullous RD, so I initially did a small retinotomy just to flatten it out, as it was not giving me much space. And once we have done a flattening out, I stained the cortical vitreous, and again the same usual step of using my forceps, diamond duster scrapers, and the vitreous cutter to initiate the cortical vitreous detachment and to take it as far toward the periphery as possible, and using my PFCL bubble to stabilize the posterior pole as much as possible, giving me a third helping hand. Once we have done it, the rest of the steps are quite similar, and in this case we can see there is a pucker in the periphery just near the aura, and they just do a limited retinectomy at that point. Now, one of the indications is there will be a coexistent macular pathology, which is an indication for doing a PPV as a first, and inverted ILM flap in these cases do come to our rescue. So this is the post-operative result. This is around 1 week follow-up. Another spectrum is that we is most commonly encountered is the Coloma RDS, and the trick here is just to do a meticulous PVD and to not produce any break. The break is most probably lying in the intercalary membrane, and to do a PVD induction without causing, because the vitreous is quite adherent in these cases, and you have to be meticulous while you are doing a PVD, and then you should not do any break. I usually don't put any band buckle around these cases, and most of these cases do very well. I also avoid using PFCL in this because there is high chance of posterior migration, and do a direct drainage from the posterior in the break on the intercalary membrane. Another interesting case is a bilateral aniridia with cataract, and presented with a morphology of a fever associated with end-stage retinal detachment. The challenge in this case was I did give a support of band buckle all around, and this we tried to open this funnel, this fixed falciform fold as much towards the. We supported it with a 240 band and a 276 tire in the limited area. And there was one more challenge was when we were planning to put silicone oil. So we did put silicone oil retention sutures. We put a cross, that is, we didn't use a 3 cross, but we used 2 crosses of tenoproline sutures to form a silicone oil retention sutures. And once we have done that, we are able to we're satisfied with the results, but this patient eventually developed a redetachment, and we had to lose this eye. So these were using a tenoproline sutures to put silicone oil retention sutures. Another interesting case is of this patient of an axial field ridger syndrome with GRT. Now in GRT, generally you associate with a complete PVD, but to our surprise, what we encountered in this case was that there was a thin cortical vitreous which was staining, which was identified. So even if you get a case of GRT, you should stain it, look for the cortical vitreous, and do a meticulous vitreous dissection, as should be with any other case. And now we should not confuse, like there might be cases which will present with an exudative RD, and if we enter in these cases, we might end up with whatever salvageable vision. So in this case, we need to just drain it from the outside. This was a patient of Coats, very advanced Coats disease, and we drained it from the outside, and the patient did very well. I mean anatomically, but functionally the results were not that great. So once we put an AC maintainer and then we did a posterior drainage, the whole of the subretinal fluid came out, and the patient did substantially well. To conclude, we must have a holistic approach in while treating pediatric RDS. Meticulous history and bilateral examination is a must. Identify syndromic association and genetic counseling. Post-op rehabilitation should include amblyopia treatment and strabismus management. The role of community ophthalmologists in early identification of pediatric retinal disease and appropriate guidance and referral is of paramount importance. Together we can save many young eyes. Thank you.
Yeah, good presentation, doctor.
Thank you.
The Coloma fundus, you said you use the intercalary membrane to create a drainage.
The break I use that parent break to drain.
You can't laser it very well.
Ma'am, what I do is generally I put,
Around the whole Coloma.
yes, with 2 rows of laser, and in the foveal area I use a single as minimum burn as possible. And I avoid putting. Thank you.
Abhishek.
Thank you, sir.
So the next presentation is, okay. This is Dr. Manu Swode, intravitreal clindamycin in toxoplasma chorioiditis. All the speakers, you have to sit here. I think Deepak has left. That's not good. And Sir Prakash has also left. At least the speakers should be.
Good afternoon, everyone. I shall be presenting my experience on the intravitreal clindamycin in cases of the presumed toxoplasma chorioretinitis. I don't have any financial disclosures. You know that the Toxoplasma gondii is the intracellular parasite which is the most common cause of posterior uveitis in the world, anywhere. And the various types of presentations you can see, there are so lots of collections of this Toxoplasma chorioretinitis in my practice, which were healed congenital toxoplasmosis as well as the active toxoplasmosis. Today's basic purpose of presenting is to report to off-label intravitreal clindamycin plus dexamethasone in a chorioretinitis cases. We have started it 7 years back with the few literature support, and to our surprise we have got lots of good results, and we will see in our cases. But what is the conventional treatment and what is the new treatment? Before that we should know that how we are treating the toxoplasma with the Bactrium DS2 loading doses, and then 1 BID for 3 weeks to 4 weeks. Same time in few cases we were adding clindamycin as well as the systemic steroids and topical steroids and cycloplegics. But why we have considered intravitreal clindamycin and dexamethasone combination in toxoplasma? Because exclusively it is an isolated local pathology in most of the cases. Intravitreal injection bypasses the blood retinal barrier, so the most of the drug is available for its action. It's high drug concentration at the target site. No systemic side effects of various drugs, which we know that the steroids are also having side effects. Sulfa drugs is also having, and clindamycin also has its own side effects, and they are very highly toxic. There is no wastage of time till the drug resistance is detected. Most of the time drug resistance is also detected in cases. In cases of pregnancy particularly, there is no contraindication because we are giving very small dose, and that too in an intravitreal cavity. It is mostly cost effective. The drug cost is very less and effective also, and it is also ideal in immunocompromised patients who are already taking so many drugs. So the method was that the dose was 1 to 1.5 milligram of clindamycin along with the dexamethasone 4 milligram at the interval of 4 to 5 days because of the half-life of the clindamycin, and 3 to 4 injections of 4 days interval were enough in all our cases. The primary outcome measure was there were changes in the Snell's visual acuity as well as the resolution of inflammation and the adverse effect if at all. So the results were the injections of intravitreal clindamycin was associated with control of toxoplasmic chorioretinitis and resolution of vitreous inflammation in all our 14 cases. All patients had improved in visual acuity. In 5 patients, vision was limited because of macular scarring, or the lesions was very close to the macula. There were no adverse reactions or complications and no need of any vitreoretinal surgery. This was the first case. You can see that this was the active toxoplasma lesion, and after injection it is completely resolved. And this is second case, 40 years male patient. You can see that typical fog in the light case, and it has completely resolved. Then this is another case which was reactivated toxoplasma in an immunocompromised patient, and it also resolved very well. This was a juxtafoveal macular reactivation of the toxoplasma, and after 4 injections it has completely resolved. This is again a toxoplasma lesion in a case 5, 20-year-old male patient, and after 4 injections it is completely resolved. This was another case, case number 6, 60-year-old male patient has suffered a toxoplasma retinitis. Basically, it was not a choroiditis, and you can see that it is completely resolved. This is again a reactivation of the toxoplasma lesion which was very close to the fovea, and after resolution you can see the complete resolution after only intravitreal injections. This is in a papillomacular bundle lesion of toxoplasma chorioretinitis, and it is resolved completely. This was again in juxtafoveal reactivation of the chorioretinitis, and this black color is a old lesion and it is completely resolved. This was a case number 10. We can see that there is a large reactivation of the chorioretinitis with the subretinal fluid also, but with the injections it has been resolved completely. And this is in case number 11. You can see that the fog in the dark light, and this again resolved, and to the safer side because of the recurrences we have done the laser to this lesion also. This was a 38-year-old patient who was having papillitis, juxtapapillary chorioretinitis, as well as the phlebitis case. And you can see on the angiography also papillitis and phlebitis. On OCT you can see the retinal thickening and port, and after the 4 injections it is completely resolved, and there is no papillitis now, there is no phlebitis also. This was a doctor patient, a 32-year-old male. He was having juxtafoveal or just subfoveal chorioretinitis. You can see on the FAF also, and after 4 injections it has been resolved. And on OCT also it was showing the retinitis lesion. This is the last case, which was a 19-year-old female. It was a reactivation of the old papillomacular bundle chorioretinitis as well as the papillitis, and you can see there was a phlebitis also, and which we don't have the post-op picture of this patient, but it resolved completely with the injections only. To the all these 14 cases, there were so many also, but we don't have the records of each and every one. But in my practice, I have seen that this is a very novel approach of giving only intravitreal clindamycin and dexamethasone, which has reduced the cost also, and the toxicity and the compliance of the patient also. And with the 3-4 injections, you get the good results. That is how the intravitreal clindamycin injection alone was associated with resolution of toxoplasmic chorioretinitis in our 14 cases. Thank you very much, sir.
Thank you very much for good presentation. And nowadays we don't see cases of toxoplasma.
I don't know.
How many years you have 14 cases?
These are not only 14 cases. I can say that these are 4-5 times more than 14 in our practice. I couldn't record each and every patient, because various consultants are there and they don't. I practice at Aurangabad in Maharashtra. Yes. So many cases are there, and these are clinical diagnosis cases, sir. Madam also might be seeing this. It is almost endemic area.
Actually, when I went to this Maldives, I was there WHO consultant, and there I saw a lot of cases of toxoplasma.
Yeah.
And basically, because of the this population, Muslim population, so they use cat.
Okay.
So cats are the
Yes, but
agent.
but in our practice, we are almost.
How did you confirm this toxoplasma?
This is a clinical diagnosis basically. This is clinical. This is a reactivation of old toxoplasmic lesions. Immediately you do know. And this IgG sometimes are a little bit higher. IgM is almost never come positive. Only in immunocompromised IgM comes positive. Otherwise, IgG levels titers are higher. That is the only thing. Otherwise,
I can make one suggestion.
Yes, madam.
If you can avoid using steroid at least every time, because all your cases I saw, even at presentation, there's hardly any inflammation where it is completely vitreous is
Yes.
foggy. So maybe first time if you want to use.
Yes.
Because you are adding to the cataract burden, IOP.
Yes,
burden,
that is there. What was the thing was that, madam, the lesions are in the vital areas. If it is a juxtapapillary or just near to the fovea, then obviously systemic steroids or.
In my experience, they resolve very well just with clindamycin.
Okay, I will just see that.
Because you are increasing the risk of end-off also.
Okay.
Wonderful, wonderful presentation.
Thank you.
We actually have some experience with the intravitreal cotrimoxazole. We published in 2015.
My
we
God.
used intravitreal cotrimoxazole for toxoplasma.
Toxo.
We actually started when the lesions were very close to the fovea and we needed a very quick response.
Yes.
So in those cases, intravitreal cotrimoxazole also worked very well. We used along with dexamethasone like you, and we used to do 1.28 milligram in 0.08 ml
Okay.
of cotrimoxazole.
Okay, okay, that's good.
Very good.
Thank you very much, sir. Thank
Another
you.
reason to use all this is now pyrimethamine is not available anywhere.
Yeah,
So we have to use much less effective drugs.
that is Bactrium DS.
Bactrium DS has a lot of side effects, plus not as effective as
Yes.
pyrimethamine sulfamethoxazole
Yeah.
combination. So clindamycin oral is not that effective,
Yes.
oral or IV. So basically I think this is the
Yes,
practical
this is a
treatment.
tracking active. Thank you very much, madam. Thank you.
So thank you much. The next last presentation is Dr. Jay Seth. Jay Seth will talk on PCV, updated VRSI guidelines and recommendations.
Good afternoon, everyone, and thank you, AIOS, for this opportunity to present these updated VRSI guidelines and recommendations for the management of PCV. Now, as we know, in our Asian population, PCV is a significant cause of exudative macular episode. Management of these patients VR and improving the visual outcomes, and there's reducing the long-term chances of subretinal fibrosis also. And multiple studies have shown very good evidence even in PCV eyes that are refractory to whether bevacizumab, ranibizumab, or even PDT. So just to summarize, the updated PCV guidelines are based on the evidence from the literature, and they emphasize that PCV is a multifactorial disorder and a timely OCT is needed for recognizing this disease entity, the extent and severity, and a tailored treatment with anti-VEGF monotherapy, especially with longer-acting agents like aflibercept is recommended. And we hope that these recommendations would provide a broader framework for the retinal physicians for the diagnosis and management to achieve optimal outcomes. So these guidelines are available for free download and reading in the August issue of AIOCMTC1. Thank you so much.
Yeah, a couple of comments. Very good presentation, as you said. The aflibercept which you said, certainly it has been studied in the Everest trial and the Planet, more importantly, not the Everest, and that has shown that it causes regression of the polyp itself, complete regression in 40% of the patients, and inactivation or non-activation 80%. So in that way, it is almost equal to photodynamic therapy. And photodynamic therapy, as you mentioned, cannot be repeated, whereas aflibercept can be repeated many times. And photodynamic therapy, when you do it at one particular area, a new polypoidal lesion or B and B can come on another area. But aflibercept would be treating the entire retina, so it prevents a recurrence from another area as well.
Okay, thank you. Very good presentation. I wish you had more time.
So, one more comment, sir.
Please.
Photodynamic therapy, would you be able to do it if you didn't have an ICG to identify the polypoidal lesion which is to be targeted? Whereas aflibercept you could do without doing an ICG.
Yeah, I think the APOIS guidelines that have been published in 2022, so that they have utilized a combination of multicolor imaging with an on-fast OCT, and they said it is almost 90% sensitive as an ICG in detecting the GLTs for these eyes. So maybe even in that aspect, a non-ICG based imaging is working.
Okay, thank you.
Thank you.
Thank you very much. We have the next session, and can we have the details of the speakers for the next session?
Can audiovisual?
All the speakers, please come to the line.
थोड़ा ध्यान से करना काम, अभी तक तो कोई ठीक हुआ नहीं है काम, लगाओ इसको.